I was discussing the role of imaging in the evaluation of myocardial disease. So particularly MRI, which is kind of my area of expertise and where the field has been evolving more. We're seeing, that the field is evolving towards actually more quantification. So the way we have been doing MRI in terms of tissue characterization, there have been two types. One of them is very quantitative, which is very good for myocardial infarctions, and is being able to quantify the amount of scar in an infarct in some non-ischemic cardiomyopathies. But now we're trying to go more quantitative into the amount of diffuse fibrosis in the myocardium, and also in other parameters like water content, the presence of inflammation, as opposed to just kind of looking at the images, trying to, again, get more accurate and objective measurements. Well, the main advantage is, as I said, is more objective. So if you have an experienced reader that is reading the MRI, you're probably going to get very good results. But people that are not so experienced, it's good to have methods that, first of all, you can rely more objectively in that there's an abnormality, and also you can use it for follow-ups and see if therapies change these parameters, they improve them or they don't. So it's also useful in that regard. Yeah, I think it's a question of better technology, of again having more advanced methods of analyzing the images that you can extract more information from the similar type of image. It depends. Like, for example, in the MRI part, patients won't feel a difference in the sense that the test is going to be the same. They're not going to notice any difference. Now, for example, if you're talking about fractional flow reserve calculation, if you're going to have a test which is a CAT scan that takes, 2 minutes, you have to hold your breath for 10 seconds, and you get the information that you would have in a cath where they have to, perk your artery, put the catheter in your heart, give you medication, then obviously that makes a big difference for a patient. So we were doing quantification of a number of parameters. We were doing quantification of volumes and ejection fraction of the ventricles, and also of certain types of scar. Now we're trying to go more kind of deeper into the tissue to detect abnormalities that are not so macroscopically evident, but you would need to have some tissue sampling to identify, but hopefully we can do it non-invasively. I think clearly there are some technologies that are not available to everybody. But we used to say that also about other technologies. When ultrasound started, it was something that few people did, and now it's kind of bread and butter cardiology. So I think that some of these technologies are going to become cheaper, they're going to become more available. And there will always be a center that is pushing the envelope and doing a little bit more. But some of these things can definitely be available, not to every clinician in every single center, but certainly in referring centers and reference centers. I think this will be commonplace. I think we're just starting to see the evolution of these technologies. One of the things I also talked about in my presentation was the evaluation of fractional flow reserve with CT, basically trying to get in a non-invasive way without giving any medication to the patient, something that today we need to do an invasive test and give medications. And this is evolving. The computers that started to do this used to take hours. Now the time of post-processing is reducing, so hopefully it will become something that can be used clinically, which today cannot yet because of the computer power, post-processing time, and so forth. But certainly, I think we're at the beginning of these changes, and there's a lot of possibilities ahead for sure.